Hello, everybody. I will talk about non-pharmacological management today and in the future. It's very interesting to think about what we can do if we're not allowed to use any actual drugs. So here my conflict of interest. I generate some funds for my department. I'm sure everybody knows the therapeutic pyramids. But it's interesting that for psoriasis, the non-pharmacological options are actually largely missing. So the only thing that we have is phototherapy. And if you want, moisturizers, which are strictly speaking, not really pharmacological options. But there must be more, and there is more. So we could use indirect treatment strategies such as exercise, weight loss, or overall addressing comorbidities of psoriasis. We could use surgery, laser, radiotherapy, phototherapy, and now let's see what the literature yields for all of this. So as a basic assessment of comorbidities, it is recommended to measure the blood pressure, BMI, wastes, serum lipids, smoking, and also address alcohol consumption in psoriasis patients. Everybody here knows the comorbidities and how high they are in severe psoriasis patients. Obesity especially is a central risk factor for psoriasis. A BMI above 30 increases the risk of psoriasis by 2 times. And we also know that the adipose tissue, it's not just inert weight, it is very active. There are lots of cytokines that are released, TNF, interleukin-6, then several cytokines specific to adipose cells, leptin, resistin, bisphatin, adiponectin, that have both inflammatory as well as anti-inflammatory action. And I think we're just starting to address the immunology of the adipose tissue. So what are the effects of lifestyle changes? Well, experience shows that losing weight improves psoriasis. And this interesting study in an unblinded approach, although has addressed with a 16 weeks low energy diet, what happens in psoriasis patients. So these patients, they had a weight loss of 15 kilograms here after 16 weeks. Okay, and what is the change in PASI that goes with it? Well, actually the PASI gets a -3 in overall, and the DLQI improves as well. And this is even more lasting than the actual weight loss that slowly comes back with a weight gain as soon as the diet is stopped. Another study confirms this. So a 20-week dietetic intervention resulted in 49% PASI improvement, and these are quite a 303 number of patients. So they had concomitant systemic treatments though. So again, here a completely clean study is yet lacking, but it is very interesting, and experience shows that there is some truth to improval of psoriasis by weight loss. Also, the metabolic profile improves after weight loss and improves response to treatment ensues as well. What about exercise? Well, the Nurses' Health study with 116,000 nurses showed that vigorous physical activity is associated with a reduced risk of psoriasis. And that's not just because they lose weight, it is there even after adjusting for the BMI. Then what about smoking? Actually, there's no robust evidence that this improves psoriasis. Pustular psoriasis, we know that there is an intense risk for palplantar pustulosis and smoking, but overall plaque type psoriasis, we don't have that good data. It also depends very much how you react to your psoriasis flare. It can start a vicious circle or a virtuous circle. So if a psoriasis flare gets you depressed and you react with passivity and shame, you may actually go to bad lifestyle choices, isolation. And this, we know that stress can induce psoriasis, can lead to a more sudden and severe flare. And now the authors of this interesting slide here show that if you do the other, if you react differently, psoriasis flare could also yield some health awareness, leading to good lifestyle choices, improved social contact. Perhaps you connect with other patients, you have new strategies how to overcome stress, and that you get a delayed and weaker flare. Now, what about surgery? Now, Professor Egeberg, who's also here with you, has done this very interesting study that I actually wanted to quiz you about 5 years ago. It's very interesting, the result that gastric bypass actually leads to an approval of really any psoriasis, even psoriatic arthritis, but gastric banding does not. The reasons are as yet unclear. Perhaps 5 years later you have some great answers. Well, you could actually just remove psoriasis by surgery. It's not a joke, it's actually been done. So in this study, after a pivotal observation as shown here, that was in the Lancet, they actually shaved this plaque psoriasis on the calf of a 40-year-old man, and leading to a really resolution of the plaque. And then they showed that you really have to shave the whole epidermis, but leave the adnexus, that scar-free healing can ensue. And the latest study showed that in 202 areas that were shaved like this, in 104, no recurrence was observed during 1.9 years of follow-up. So actually, they probably shaved all the T resident memory cells away. Now, a bit less dramatic is occlusive treatment. So in 1985 as well, Dr. Shore in the New England Journal published that after a biopsy was taken, they forgot to remove the dressing, and that actually led to resolution of a psoriasis plaque. And so this has then later on been studied systematically, and occlusive treatment with hydrocolloid dressings achieves resolution of plaques in 47%. Then laser. You can use laser directly against psoriasis, but that doesn't have a great effect. On the contrary, you can actually Koebnerize psoriasis. But of course, if you use a fractional laser to shoot small superficial holes in the psoriasis affected skin, you enhance the penetration. For example, of calcipotriol, and here this study was done with a laser or without the laser. Both got calcipotriol daily, and the laser was done weekly, so this is every week. And even though the difference now is probably not so impressive to you, it's not impressive to me either, but the study, which was unblinded and just 5 patients, they have a really great p-value. Not sure whether it's actually corrected from multiple testing, but just saying there is one reference that shows that laser has a potential in penetration enhancing of topical drugs in psoriasis. Now, radiotherapy, that's also very interesting. So of course, that's a traditional strategy to treat inflammatory dermatoses, so palmoplantar psoriasis, eczema, were irradiated in an unblinded study with 0.5 to 1 gray twice a week, up to 4 to 5 gray. And in the you got a near or complete remission in almost all patients. They're actually a study from Basel. Follow-up on average 20 months. Only 11% did not benefit. And here for scalp psoriasis with grains rays that do not penetrate deep enough to actually induce effluvium, you can have here in a double-blind study really showing that almost all patients got complete healing after 6 weeks of treatment. The risk of malignancy, incidentally, is actually very low. So 14,200 patients were actually analyzed retrospectively, which led the authors to that result that they discussed it. Even if there might be a risk, it can't be shown. Now, phototherapy is, of course, the mainstay of the non-pharmacological interventions. And this slide is inspired by Professor Wolf, who talked at EADV. Very nice introduction that he gave into phototherapy. So there was painstaking research to find the best action spectrum of ultraviolet light. And in the end, one found that it's actually in the UVB narrowband spectrum. UVA has little effect. You can see here that's the erythema curve. So here you get less erythema, here you get more. And the efficacy against psoriasis is actually here, the green peak. And of course, when it goes towards the right, well, there is little effect anymore, except if you combine it with Psoriasis, then it works again. Now, you can see here quite impressive results. A patient that was irradiated 3 times per week with UVB narrowband using the classic half-side approach. The patient also got Glyphosate, but that's not to the point here. And the UVB narrowband has quite a high PASI 75 of 62%. It's almost as effective as the weaker biologics that we have nowadays. We typically advocate against using UVB narrowband at home. That may not have just financial reasons, but it's something that patients often discuss at least a few years before. I often had discussions with patients because there are devices for home treatment. There's great demand for this. You can treat yourself, drug-free, it's convenient. You can just hang it on the wall in the cellar somewhere. And it's been shown that it's equally safe, it's effective on clinical features and quality of life, and it leads to a low burden of treatment, obviously, because you don't have to come to the outpatient clinic, and a higher satisfaction. And this has actually been addressed in a study comparing outpatient and at-home treatment. And of course, the disadvantage that we often cited is that uncontrolled accumulation of UV-induced mutation, and one suspects that there might be subsequent skin cancer. We've probably all seen patients who really did this for a long time, and at least there is no study actually showing that UVB narrowband alone actually induces a high rate of skin cancer. Now, outside the active spectrum, there is now renewed interest in blue visible light. You may know the light as the one that can also induce pigmentation, and that is not covered by traditional sunscreens. And so here, that's the spectrum where you then find the blue lights really on to the right of the UVB narrowband spectrum. So how effective is it then? Well, if you use it 15 minutes, 3 times per week for 4 weeks, and compare it in the same patient with topical steroid, you can see here where the blue cloud is, you actually have the blue light treatment, and after here 4 weeks, you have a nice result that is really comparable to steroids. So the studies that were done, I would say they're quite weak, but it's still always labeled as being good. And the study has certainly enabled Philips to get that device on the market, and they are selling it since a while now. So this slide is inspired by apparently Professor Tanev and now from Professor Wolf's talk. Very nice, comparing phototherapy and biologics. And you can see that you can use phototherapy in many situations where we actually have a problem with biologics and small molecules. Internal neoplasia, tuberculosis, hepatitis, HIV, pregnancy and lactation, very good. I wouldn't really say that it's very useful in children, depends what age they have, and biologics, some of them are registered for children, so there it's not a problem. There's certainly no drug interactions, and you don't have an effect on inverse regions though. And nails, scalp joints, they all don't really profit from phototherapy, but of course they do from using systemic treatments. And the other points, I think, we'll leave for you to read to gain a bit more time. So in the end, the therapeutic pyramid that includes now non-pharmacological options is shown here. You can see you have the physical therapy, phototherapy, but also novel light-based treatments, radiotherapy, and as the basis really for every psoriasis patient who has comorbidities, should they have weight loss, exercise, and further addressing the comorbidities correctly. So non-pharmacological interventions for psoriasis are possible. There's a wide range of therapeutic options available, and perhaps the most helpful is actually if you change the behavior of patients, especially to induce weight loss. And with that, I thank you, and best regards from Switzerland.